All right. Well, I want to welcome you to the HIM seminar series, and it's my particular pleasure to welcome Dr. Marge Benham-Hutchins. She's currently an associate professor and the interim chair of the Department of Biobehavioral Nursing Science at the College of Nursing and Health Sciences at Texas A&M University in Corpus Christi. And she's also an associate editor for the Journal of Participatory Medicine and a lifetime member of the Society of Participatory Medicine. We're excited to have Marge here today because she's going to talk a little bit about a couple of her studies and how they relate to patients and their access to their own information during hospitalization. It relates to her current work, the Bridge the Gap Research Project. And part of that is looking at the outcomes of what happens when patients have access to this information and whether or not it influences their ability to manage chronic diseases after discharge. So again, I'd like to offer a warm welcome to Dr. Marge Benham-Hutchins, and I'm sure that we're going to find out a lot of interesting things about patients, hospitalization, and what people actually have access to. And I bet there's going to be a lot of questions at the end as we start to think about how we might apply some of these same lessons to the health system that we have here. So without further ado, I'll turn it over to Marge. Thanks.
Thank you, Karen. Thank you to everybody for this opportunity to present my research. I have the slide right here because right now I'm at the Island University, and this is our actual campus on the island here. That is a beach, and my office actually looks out into the ocean, so it's really kind of cool for this Connecticut girl to be down here. So basically what I wanted to do today is I decided to take one step back to provide a little information to my original interest, because there were things that happened during that study that helped me identify what is now my research trajectory. So I'm going to start with just a quick overview of a study that I looked at provider-focused communication and information exchange. And this was really looking at it from the point of view of multiple professions communicating and with a hybrid information system. The system I'm going to show you is going to seem a little old depending on your system, but now that I'm in another part of Texas, I realize that it actually is not that different than what is still happening here. I also had another study measuring network stability and fit, and I thought that was too much to really include in this one. So I do have some publications in that if you're interested more in network analysis. So then when I moved to the other studies, including the patients, I looked at exploring patient-centered handoffs in surgical oncology. And then I have two Bridging the Gap pilot studies that I'm going to present also. So I'll be happy to answer any questions. So this is the earlier study that built on my interest in communication in the healthcare environment and how technology could help. At that point, I was totally focused on providers and providers exchanging information. So this study looked at that. I'm going to show you quickly, just as a little background to what I built upon. So this patient information documentation system was what was in that hospital. And I thought this was not happening anymore till I moved down here. In a lot of the rural hospitals, it's very similar. So this study, I was in the emergency department and I was looking to following patients that were transferring to inpatient units. So they started in the emergency department. So one of the first things I went is to see what is the documentation process and what options do they have. So in this particular case, they were using a lot of different things. The emergency, the ED nurse, the emergency department nurse in the lower left side would call their report to the admitting unit nurse. They also had handwritten charts there, and they were basically a clipboard that they exchanged and had in the pocket outside the patient's room. And they also scanned that into something called ChartMax. And then from ChartMax, it was then uploaded into electronic health record where providers in the admitting unit could see that information, but it was the handwritten scanned copies. It also was not always available in a timely manner. And then they had computerized provider order entry. But what was interesting here, and this is a whole nother study, but they put that in without really looking at the output. So they're actually transcribing medication orders back onto paper, which you could see how that would add to the complexity. And then in the admitting units, they had partial in the EHR, they had a handwritten SPAR handoff, and then they had a paper chart. So consequently, you could see this is very, very complex. And it's not really surprising that I use social network analysis, and I'm happy to provide some papers in that. I think it's kind of beyond this, the scope of this discussion to go into it in detail. But basically, you develop sociograms, and I contacted everybody, physically followed the patients from the emergency department to the units. I identified providers and asked them to identify who they were speaking and communicating with and how. So we got some ideas for that on what methods they were using. Were they reading electronic record? Were they calling? Were they actually physical proximity? So in this particular case, the real central person was the charge nurse in the admitting unit. And this was interesting because this charge nurse took report because the bedside nurse was caring for patients, and then later gave that report to the primary nurse. And we identified that there was a boundary spanner here. So that elimination would have really broken the two networks apart from the ED, as you can see over here, and the admitting unit. And there were lots and lots of different documentation processes and concurrent verbal conversations. It was very, very complex process. So from that particular study, that's just one snapshot view. And you could see this is a very nonlinear, unpredictable communication. There were lots of things that influenced it: the staffing, the providers, the information infrastructure, and the physical infrastructure. So, but I got to this point and I said, well, what's missing here? There's something going on. And I realized that in my role as researcher, where I physically followed the patient, I waited in the ED until I got a patient consent in that. And I physically followed the patient through the halls and everything so I could identify. And I realized that I had more information than the patient did. They looked to me with questions, and also providers. In the ER, they would see me and they would say, well, has this person been in to see the patient? When I got to the floor following the patient, they were asking me questions like, who's the admitting doctor? And I had to throw out one of my observations because I answered them and I realized I influenced it. And so after that, I would just look very quiet and stupid and kind of sit in the corner. But I really realized that there were a couple things going on. My research was looking at how to tighten up the communication between the providers. But I really realized that the patient is out of the communication loop, and they depended on me also to bridge that gap. So that led to my inquiries into patient participation and patient access to information in the inpatient setting. So that led to a study where I work with Nancy Staggers and Laura Langford Herman on a study where we looked at patient-centered handoffs in surgical oncology. So in this particular case, we were really looking closely at the bedside handoffs from the nursing perspectives. And these were nursing bedside handoffs that the nurses were just starting to do, where they would actually, at the end of their shift, exchange information in front of the patient and discuss things. And so this setting was a large cancer center in the Western US, and it was a dedicated 25-bed surgical oncology unit. We used purposeful sampling to select patients that we were looking for diverse gender diagnoses, and I'm sorry, I have things covering my own notes here. Looking at diverse diagnoses, features of their disease progression. We were also looking at their age. We were trying to get a range, gender. Education, we didn't select for that, but we actually ended up with 50% from college, and 2 had not graduated from high school. We ended up with 10 male and 10 female. We did observations, interviews. We recorded the interviews, and it was a researcher created interview tool, and we recorded, then they were transcribed. And we also were very interested from a user experience and our overall interest in what kind of technology could be used in the healthcare environment. for patients, we were interested in what we called artifact tool capture. We were looking to see, are they using any kind of electronic device themselves, or is there anything in the hospital itself? So, and we use qualitative content analysis. So it was interesting when we questioned people about what information they wanted and their participation. There were the codes, we had 356 codes, and narrowed it down into 3 themes. Depends upon how sick I am, I want to know everything, and my life is in their hands. My life is in their hands is a very interesting one, because some of this had to do with their perception of the nurse's role, or the perception of their own role as a patient, and was it okay? They wanted to be a good patient, have people take care of them. And so that was an interesting finding. Also, I want to know everything. They did want to know. They wanted to know the preferences. They wanted discharge information. They wanted to see the EHR information, which at that time they were not able to see it. And occasionally somebody might turn a screen and show it to them. But they really felt like there was some secretive stuff going in there, and that some of the provider behaviors where they would talk around the screen in hushed tones and that type of thing was disconcerting. And then they also said it depended on how sick they are, and that had to do with the actual barriers to participating and that type of thing. So we thought this was really interesting, because the patients were really interested. They weren't sure of their role, and of course it would depend on how sick they are. Like, maybe somebody who's just come back from surgery may not be ready, but they would want to be, filled in later. We also discovered that none of the patients in this sample used electronic tools for this purpose. They did have electronic devices, some had iPads and that, but nobody used it for that. They took notes themselves. One of them showed us a diagram that a physician had drawn of their issue, and it was kidneys, and showing that type of thing. Family quite often were the ones keeping track, and the patients themselves, one of them referred to their brain as their file system, that they remembered things. The only thing that was a communication tool between the providers and the patients were the whiteboards. And you could see one of these was one that had practically nothing on it, and there wasn't much. The other one, there was a little bit more on it, but still very limited information that the patient could use in terms of determining their care and then planning for that discharge. So that study, I'm happy to provide anybody who wants with the actual, copies of the articles or whatever you want, because these are real summaries. So after that, moved into what we were calling the Bridging the Gap studies, because we started to acknowledge that there was this big gap, and that it was between the patients and the providers in the healthcare environment, but also we started looking at chronic disease self-management and patients' experiences with being self-managing a disease, let's say like cancer or diabetes, being hospitalized and then going home and resuming self-management. And so our interest is how did that hospitalization influence that? Did they have the information they needed in order to go home and continue care with whatever changes might have occurred? So the first study, we had it was interdisciplinary research team, and we had a patient on the research team who helped us with the questions, helped us with the interpretations, and designing the study. And so that was really great. We had a health communication, and we had nurse informaticians and nursing people on there. So it really helped us look at this from a bigger perspective. So once again, we were looking at what happens in the hospital and what might have changed, and were they able to maintain and self-manage. And this one, part of the pilot was we were doing what we had nicknamed social media snowball sampling. And basically, we asked people to share the information with other people who might meet the criteria criteria for the study, which were people who had been hospitalized, had a chronic disease, had been hospitalized, and did self-management. And so consequently, we used online support groups, listservs, blogs, social media. And what was really interesting, we ended up with 34 participants, and they represented all of the regions, all 4 regions in the United States. And so it actually spread pretty far out there on the web. And so we thought that was interesting. And we also have representation from urban, rural, and suburban hospitals. And we asked the patients to self-identify the type of hospital that they were in, and we gave them some criteria for that. This particular group were most female. We had quite the range, 20 to 76, which some people had told us or had projected that doing it online, we were going to limit it to only young, tech savvy, but actually it ended up with the mean of age 48 and standard deviation of 16.87. So consequently, we really did have a very diverse age sample. We did have a bias in the sense that they were very highly educated. And I think that might be representing, the way we collected the data. But 29% had some college or tech. College grads were 32%, and then graduate or advanced degree was another 32%. So we had a very highly educated sample that participated. So that's something, like I said, we were piloting the data collection method also. I want to acknowledge that we did get funding from this from NINR and the Center for Transdisciplinary Collaborative Research and Self-Management Science. And anything I say is my opinion. And IRB approval, we got on all of them from all the important. So this one was interesting because once again, that I want to know everything came out. Many of them were very frustrated with access and sharing of information while they were in the hospital. When we asked them about bedside report and medical rounds, one patient actually said that he felt like a monkey in the zoo in the medical rounds, and everybody came in and looking at him, and they didn't really include him and ask him questions, but they were talking about him. And the same thing with some of the nursing rounds. They wanted the information so they could care for themselves. They wanted the discharge information. And they mentioned that what they got quite often was an electronic printout with a bunch of information. And I'm not sure how it is in Canada, but here in the United States, it's very hard sometimes to get copies of tests that have been running in the hospital in a timely manner to your providers. Technically, they're supposed to be sent, but they don't always happen. So people might have had testing in the hospital, go to see a provider, and they end up with things being repeated and that type of thing. Again, they wanted to be included during bedside shift report. This group also mentioned some provider behaviors that they found were bothersome, and that turn them off, like the whispering around the computers, or acting like they're not in the room, or not including them in things or acknowledging their questions. So, it was once again the same type of thing where the patients wanted to be involved, and there were a variety of factors. And I think there were environmental, organizational, but also some provider behaviors that excluded them. And then many of them then said that when they were discharged, that there were gaps in the knowledge they needed and what they needed to continue self-care. So we thought that was good information, and we're using this to build the next study. But we almost simultaneously did another Bridging the Gap study where we wanted to look at Spanish-speaking patients. And for this particular group, once again, we had an interdisciplinary group. We had people from communications and nursing and informatics. Same idea as the other one, except we used a focus group for this, and we recruited from a local oncology clinic that was associated with the hospital that's right next to the university. And so the patients actually physically came to the focus group, and we planned for quite a few, but because of some issues going on in the United States at that time with immigrants, a lot of them were really worried about coming to our focus groups. And so we ended up with just the one, but, and there were 7 people that participated. So it wasn't exactly what we wanted, but we did get the one. They ended up being all women, the average age of 55. The chronic diseases included cancer, diabetes, various comorbid conditions, hypertension, arthritis, heart and liver disease. They had all been hospitalized between 2 and 8 months previously for 2 to 14 days. And the funding for this came from from another foundation, and we obtained IRB approval from the University of Texas at Austin, but we also made sure that we had Spanish language consent, and our focus groups, we had a Spanish-speaking moderator who also transcribed the discussions, the recorded discussions. And why we really wanted to do that is that she did it within the context of the language and not word for word interpretation that might have missed the message and the nuances and that type of thing in it. And very experienced focus group moderators that really did an excellent job. What was interesting about this particular group is that they were very, very happy with the care they wanted. In contrast to the other group that really was unhappy and wanted more, it appeared that most of these participants, were very grateful for the care they were receiving. None of them in the group thought language was a problem, that there was enough translation services. And we thought this was really interesting because the main thing that kept coming up that was blocking was not something with the providers or the organization. It was something within the patients themselves where they said they were not what we termed emotionally ready, like they weren't ready to really know yet. And that really influenced it. But they felt like they got enough information and they were very happy with it. So this kind of put a little bit different, oops, sorry about that. This actually put a little bit different swing on it, because we had 2 different studies that showed patients that really wanted more, wanted to be involved. But this particular group felt very content with what they were getting and they were happy. So, this was something that all of these studies together really led to us wanting to know more about the different population groups and the different things that influence. And we got very interested in inpatient portals. I don't know if you have them there or not, but here a lot of the portals patients had started to get through their doctors and that kind of stuff were not available. Information in the hospital a lot of times was locked down, and providers were not allowed to print out information. Some of the hospital regulations were such that you could get your discharge in your hospital records, but they had 30 days to give it to you after your discharge. So if somebody is in the hospital, needs some information to actually make decisions, then they were really in a position where they had nowhere to turn, and people got very, very frustrated. And so consequently, we realized there was a real need for that inpatient portal where patients will share, and there's a lot more of those being developed across the country. It's still not very widespread. I don't know of any in my community here, but I do know that we have that in Boston, and Stanford has it, and I think Kaiser Permanente, and some of the recent rules here in the United States are that patients now through the HIPAA laws have access to their information. And so medical records are now being put out there and doctors' notes, but there's still a gap there on people that are hospitalized and getting real-time information. And one of the things that we projected is that if patients were actively involved in the hospital, that they would then have better outcomes when they go home, they'd be prepared, but also have an influence on medical error. Because if a patient knows that something is supposed to happen or there's a change in medication, they are many times the most vested person in terms of being able to say, no, this is wrong. No, why am I getting this medication? And if they're informed there's been a medication change and they actually know about it, than we're projecting. So we had planned to take these studies. We were pulling them together, and I moved to the new university and was getting set up last fall and had a variety of things ready to jump in. I was going to do a pilot at the local hospital where we would actually go in and look more at the provider behaviors and that type of thing. And of course, best laid plans. The study was going to be facilitators and barriers to nurse and patient information exchange. Then the pandemic hit. And of course, things got locked down here. And a lot of the research we wanted to do, we needed access to the hospital. But then our team and a few other people joined us, and we looked and we realized, wait a minute, we have a whole new set of communication issues going on. And that's what we teamed this No Visitors Allowed. And we decided to call it that. We got some funding from the Just-in-Time COVID-19 Research Fund at my current university. And we started looking at, when we say patients, visitors aren't allowed, what happens? And so, patients, caregivers were not allowed to come in, even to the ER. Patients were in the hospital and were not able to be with their loved ones, were not able to communicate. There was also, our research is showing that there were a lot of providers that were not seeing the patient. They were communicating by the phone. They could be different things. It added another complexity to the whole thing, is that people were wearing personal protective gear. And so consequently, there were problems with identification between providers themselves on who was who, but also patients and who was who. And they didn't have their caregivers there. And so as we looked at this more, the study has evolved because people started coming up with solutions. And in the news here, we hear a lot about people who, have had iPads, or nurses use their iPhones to connect patients with their family. Some of the telemedicine technology has been used so that patients in isolation can then have a visit with the doctor and their family, and they can use that type of thing. So there's communication that way. That's not totally widespread. The visitor situation fluctuated as the pandemic went on. And so our local hospital just put out a directive where they're going to allow what they're calling patient support personnel or persons will be allowed in, and visitors, they distinguish between visitors and these people that are actually support. And so that might be somebody who's like a caregiver, a family caregiver. Sometimes patients, they may need support because of a variety of their own communication. They may have different communication needs themselves. They may have hearing or vision deficits. And a lot of times the caregiver for somebody with chronic disease may be the one that holds a lot of the information. So we're looking at that a lot more now, and looking at these solutions. In our study, we're looking into what type of solutions where people using technology-based solutions have been implemented to help with this communication between families, patients, and the providers, because all that stuff I just talked about is still present, but now we add on this additional complexity to it. So I'm hoping that that has been such a fluid project, because every time we think we're ready to publish, something else happens and we're like, wait a minute, we need to do this too. So that's a very fluid project. And I'm hoping that that will continue. And also, I think there's a lot of retrospective knowledge we can gain from this pandemic and the way we've responded to help us in the future be maybe more prepared for this type of event, whether it's short term or not. When I was doing another study in a hospital in Dallas was when there was an Ebola case, at one of the hospitals there. I think it was the only one, it was one of the first ones in the United States. And that study, as part of it, we did a secondary analysis looking at communication during that time period. And I didn't include that in this one because of the time factor, but that was something that was once again a pandemic type of situation, which was stopped. But I think going forward, we may run into more. So what I wanted to do is sort of open it up to questions and discussion. Here's a couple of the ideas I have for future research. I would love to hear from people about, their experiences and, is Canada different than the US? I mean, are things different there? And then kind of go from there. I don't know if everybody's muted or is there a discussion?
Yeah, actually, so I think everybody was muted for your presentation. But I get, so at this point, folks can unmute themselves to ask questions. And then there's also a chat feature where you can also write your question if you have questions.
Okay, so I think if I end the screen sharing, I can see the chat also. So is that okay?
Mm-hmm.
Oh, there we go. Okay, sorry. Let me see. There's the chat. Okay. Sorry. Technology,
Yep. Great. Well, while we wait for folks, I do actually have a question for you. So
sure.
You had talked about looking at inpatient portals. Can you describe a little bit what they look like? Because I actually have not seen one of those up here in use.
Well, I was actually part of a little think tank that was developing them. And there were 3 different prototypes I witnessed. And these portals were, I'll use the example of one that had kind of a monitor that was on an arm that could be moved and the provider or the patient could see it and they could watch TV and do that from it. So the inpatient portal part of it actually provided them information on the providers that were caring for them, information on the shift change and pictures and that kind of stuff of who it was. The other thing it had in there was access to their medication list and their treatment list. That particular one, I did not see. They were working on a way to tie it to more information. But at that point, they want patients to know about their providers and sort of their schedule too, because some of the patients are, they're laying in a bed and a gurney comes and says you're going for a test. And so hopefully there'd be a little bit more of a heads up. They would know and prepare. And they also had communication. And this, I think, was really a key in that a provider, the old story of somebody's family member sitting in the room and you get up to get a coffee, you come back and find the doctor had come. I mean, it just seems like doctors are really good at that. And so consequently, there was a communication aspect of it. So the patient could text the provider and say, these are my questions. And so it could be answered. And then caregivers could have access to it and could look and see those answers, could also see and ask questions. And so that 2-way communication with the providers, other than sitting in the room, but actually having that interactive. And I'm trying to think, there was another one that they prototyped, and I have not been able to go and see them in actual work. But that one, I think, was the one from the group from Stanford. And then in Boston, the one they were doing was going to build on their Open Notes platform. And so the patients had access there to a lot of information, patient notes, so they could see the actual nurse's notes, they could see the physician's notes, they could see all that. So consequently, they could stay actively involved and updated. One of the discussions there, I remember, I'm trying to recall the exact details, but if I recall correctly, the patient was a surgical patient who had come out of surgery and was feeling better and actually used the portal to catch up on what happened while they were not able. So they were able to go back and say, oh, the surgery, this, oh, my medication's changed. And they were able to see a lot of that, and they were able to do that. Now, we all know there's patients that aren't going to be able to interact this way, but if the culture changes, it might be something that would be expected, because as open notes spreads across the US. Now, in Canada, you have open notes like that where you can read a physician's notes or any of that yet?
I'll let other people